Welcome everyone to the February 2025 edition of Eversight's webinar series, the first one this year. Tonight we have Endothelium-in DMEK and complex eyes with Dr. Chris Salas. Just a few housekeeping notes before we get started. This webinar, all of our webinars are recorded and available on demand on our website and YouTube. Please keep an eye on your inboxes for more webinars coming up this year. In May, we'll hear from Sophie Dang of Jules Stein Eye Institute on the management of limbal stem cell deficiency. All participants are going to be muted through the duration of the webinar, but please do ask questions. There's a little Q&A box at the bottom of your computer screen or on your phone. Type them in there at any time, and they'll be answered at the conclusion of the talk. Also, you'll be asked to participate in a brief survey at the conclusion of the talk, and we do invite your feedback. So now, a quick few words about tonight's speaker. Dr. Chris Salas is an associate professor of ophthalmology at the University of Iowa, Department of Ophthalmology and Visual Sciences. He specializes in minimally invasive cornea transplant surgery. He earned his medical degree at Tufts University School of Medicine in Boston, completed ophthalmology residency at Stanford, and then completed a cornea fellowship under Mark Terry and Mike Strako at the Devers Eye Institute in Portland, Oregon. He's now an associate professor at the University of Iowa Carver College of Medicine. He has authored 4 textbook chapters and numerous medical journal articles on DMEK, which we are going to hear a lot about tonight. And he's also developed specialized instruments, surgical techniques, and novel training tools, which I use all the time for wet labs personally, and maybe you have too if you've ever done a wet lab with us. And with no further ado, I will turn the floor over to Dr. Salas for the talk.
Thank you. Thank you very much for that very kind introduction. And thank you to Eversight for having me. If you're tuning in from the East Coast, it's about 7:30 your time. And I'll make sure that we really respect the time because it's going to get late over there. Okay, so these are my disclosures. So I don't think any keratoplasty talk could be all that good if you don't start with this chart that everyone always shows. And the point here is that over the past 10 years, the green line, DMEK, has really grown pretty steadily. And it's now more popular than DSEK. And most of the reason why that is because people are doing it for Fuchs dystrophy. But certainly there is a proportion of all of this that comes from doing DMEK in eyes that previously had been thought to be only DSEK eyes, and before that had been thought to be only PK eyes. And so that's sort of a nice intro into thinking about complex DMEK, and in particular, pull-through DMEK, endo-in pull-through DMEK. So there are at least 2, there's more than 2, but there are at least 2 kinds of DMEK surgery. These are some older videos from when I was at Cornell. I can tell because there's an S on the tissue, and I usually now use F stamps. But this is the DMEK that everyone sort of knows about, right? This is endo out, injected in, use bimanual technique. This is my favorite way of doing it with duress and remove. And, you're good to go. I don't put in all these sutures anymore, but at the time I did. And, it would be complex because it's an eye with a glaucoma tube. Here's an eye with an ACIOL that has clearly had a vitrectomy and also has a tube. And this is one of my early cases of endo-in pull-through DMEK. And what you can see here is that this tissue, which has been folded against its will, endo-in, then basically opens itself after it's pulled through. And there's an AC maintainer, which there isn't in the conventional way of doing endo-out tap technique DMEK. So if I step back for a moment and talk to you about what's at play with both of these techniques and how we use forces, and this is sort of the way that I think about surgeries in terms of forces to our benefit. Really the forces that are at play in all DMEK surgery is the recoil force of the tissue, and then there are flow forces that make the tissue move or parts of the tissue move, and then there's friction forces that keep parts of the tissue from moving or keep the tissue entirely from moving. And in conventional endo-out DMEK, we are using the frictional forces that are generated by the posterior pressure of the eye, which pushes the iris diaphragm forward and then pushes the tissue up against the cornea to some capacity, not entirely, but somewhat, so that it basically braces the tissue open. And we are fighting the recoil forces of the tissue, which makes it want to kind of continue to close back up again by having this limited space in which the tissue opens, and it's opening from there being a flow force from the tapping, and then it gets stuck on the cornea. And that's what is allowing for conventional endo-out DMEK to work. And, everyone is very familiar with this. If you have the chamber balanced appropriately with the right depth, it really can be like taking candy from a baby. I mean, you just have to tap on the cornea. It generates those fluid waves. The cornea is up against the iris sufficiently to allow for the tissue to stay open, but not so much that the tissue can't open, and everything is easy peasy. Endo-in DMEK is conceptually a different approach, where now you're using the recoil forces of the tissue, which make it want to go from this position into an endo-out position. And you're using these forces to make the tissue open itself. And you're using flow forces really to keep the chamber deep enough to make the tissue open. And you're also using flow forces to blow down the barrel of the tissue to encourage it to open. Frictional forces really are not much at play here, other than that you're holding the tissue up high against the cornea so that when it opens, it hits the cornea, and it's not going to continue to go all the way back around into its endo-out configuration. This is the first endo in pull-through DMEK that I ever did. It was in a lab, and I recommend trying this in a lab because it really gives you an idea of how it works. And it's essentially, it looks like it just opens itself because it does. And that's all because of the recoil forces. So what defines complex DMEK in my practice? Well, to me, it's all about how I open the DMEK. And the approach to opening the graft defines complex DMEK to me. So an endo-out tap case, that's a routine case. And an endo-in pull-through case is a complex case. So when do I do endo-out DMEK, conventional tap technique DMEK, in eyes that will shallow? And that means eyes that have normal anatomy, in particular, the non-vitrectomized eyes, but they could still have other issues like tubes. That's okay for endo-out tap technique DMEK for me, trabs, MIGs, even ice, and even a failed PK. As long as I know that that chamber can shallow and I can modulate all of those forces that are at play between the balance of the recoil forces of the tissue and the frictional forces between the cornea and the iris plane. So these cases, you might say, well, these are not like routine cases. These are complex cases. I'm even sticking, Wexel sponges behind the lid speculum to augment the pressure of the posterior pressure on the left there. But once I have that chamber balanced, I mean, it is a straightforward tap technique case. On the right, I didn't have to do that, but I have issues with visualization because it's a failed PK. And here I use a double scroll technique and inject the tissue that way to really facilitate getting it open very easily. And then, of course, the light pipe so I could see a little bit better. But both of these cases are good examples of non-routine eyes that most people, I think, would consider complex. That I would just say, just for the sake of just keeping the naming simple, these are tap technique cases to me. Complex cases, but tap technique cases. And they bring a different level of attention for me than a pull-through case, which has another layer of difficulty, in my opinion, as in the way that I do it. So just because I showed a video on it, I think that it'd be nice to kind of dissect what I was doing on that right side of the screen, which is I use a light pipe. This was first published, I think, by Susan Jacob, DMEK, I think she called it. And I just use a 20 gauge light pipe. I may or may not shut off the microscope light. And the thing that I really like to do when it gets hard to see is to use a viscoelastic bead on the cornea like this. And that's that same case that I was showing previously. It was on the left of the previous screen. And basically you can see that once I contact this light pipe to that viscoelastic, basically the light conducts right into the cornea. It makes it really easy to see the Descemet's membrane during stripping, and I double check it with the bubble. But I love using a light pipe. just make sure you don't touch it to the cornea if you do this technique because it will burn it. Okay, so this is all my long way of saying to all of you that endo-in DMEK is not easy, and that's why I call it complex DMEK. It can be unpredictable, and it is always, at least in my hands, an ergonomic challenge, and I'll explain to you why that is. So here's a straightforward pull-through DMEK case. And if all cases went this way, you might say like, well, you know, why don't you just do all your cases this way instead of doing an endo tap technique? And that's because all cases don't go this way. And if I fast forward here a little bit and bring it to here, maybe, you know, on the exit here, the AC maintainer is helping to blow this thing open. Those are the force, that's the flow force. And I'm making sure I hold that force up high against the cornea. And, you know, again, this looks pretty straightforward. And then I get a bubble in there and, you know, it looks like this is, you know, what's so difficult about this? But you know, I warn you, endo-in DMEK to me is not a replacement for endo-out DMEK, at least with this technique. And there's other ways of doing this without an AC maintainer. You can use a Descemet, et cetera. I don't have access to that at my institution, and I'm just going to give you a talk about doing it with an AC maintainer. But you know, here's a complex case. So here's you know an eye that I can't seem to get the tissue to unscroll itself using the flow forces of the AC maintainer. The bubble goes in there in a wonky way. Now it's pushed the tissue over off into the corner of the AC. And now I've got to get this thing over centrally, and it's too far over for me to just start hitting it. So I have to pull it up and over the bubble and into position. And like, this is not an easy maneuver. I mean, the AC maintainer makes it easier for sure. But, you know, this is not something that I think about like, oh yeah, this is like easy, straightforward DMEK that I want to be doing all the time. And I'd love to tell you that no cases end up this way, but I think you have to be ready for a case to end up this way if you're going to do endo in pull-through DMEK using a technique like this. Having said that, once you get comfortable grabbing DMEK tissue with forceps in an eye that has an AC maintainer in it, it becomes very helpful when you have trouble with DMEK in any setting, particularly if you have things like blood and fibrin and what have you, because you get a much better feel for what you can and cannot do to that tissue when it's in an eye that has a bunch of AC maintainer fluid going into it. So to me, endo-in DMEK is a good second technique. And I would recommend learning endo-in DMEK only after you have mastered endo-out DMEK. Just a little bit of data here. This is a study out of Singapore, and you know the EndoGlide. It was developed first for DSEK by Dr. Donald Tan, and his group continued to work on that. And he also then developed the endo-in DMEK. And this group basically found that their endo-in technique gave comparable, if not better, outcomes to the endo-out technique. And it makes sense if you think about where the endothelium is and what kind of trauma is being put on that endothelium as it passes through, you know, a piece of glass with all the tissue going up against the edges of the glass. So when do I do endo-in DMEK? And I do that in eyes that will not shallow, and that's in post-vitrectomy eyes. And so that's definitely eyes that also have an ACIOL. But for me, I do it in those eyes that have an ACIOL because I can't tap on an ACIOL, right? That's going to kill the endothelium if it's an endo-out DMEK. Likewise, I can't tap on an iris prosthesis. And this is sort of a little bit of a nuance, but I can't tap on a widely dilated pupil after I do cataract surgery if it won't come down because it's going to be tapping on the IOL. And so I also do endo-in DMEK pull-throughs if I'm going to do a planned triple, which is probably quite different from what other people do. But I don't usually do routine triples. I usually stage my surgeries. But if I have to do a triple, I'll do it with an endo-in pull-through. And that's because I don't want to have to think about what the pupil's going to do. So I just widely dilate the pupil like crazy for the cataract surgery. And then I deal with an endo-in DMEK as if there's an ACIOL in the eye, even though there isn't. And then I don't have to think about having to tap on anything or losing control of the tissue into the middle segment there. So I also do it in eyes with nearly opaque corneas. And that's because having a forcep on the transplant allows me to have a lot more control over it. And I'd rather take my chances in a situation like that than having to like indirectly manipulate the cornea with tap techniques in an eye that I can barely see into. So if it hasn't become clear, I mean, I really think that endo-in DMEK is a second technique, which then would sort of make it in your armamentarium of techniques be an alternative to complex Descemet. And if you're a great Descemet surgeon, you might be like, why would I even bother doing endo-in DMEK if I can do great Descemet? Let me kind of get into that a little bit in the next couple of slides. So for me, endo-in DMEK and any kind of DMEK is a more efficient surgery, both in the operating room and outside the operating room. And that's because once a bubble is underneath DMEK tissue, because there's no additional stroma, and because there's the memory of the DMEK tissue is easily overcome by that tamponade, you don't have to think about interface fluid evacuation steps. So you don't have to think about bringing the IOP up high enough to do it. So in an eye with glaucoma, that might be an issue. You don't have to think about sweeping. You don't have to think about venting incisions. If you are thinking about the thing detaching in Descemet, you don't have to do suture retention steps. You don't do any of that. And when there is a detachment in DMEK, in the vast majority of cases, not all cases, but in the vast majority of cases, it's a partial detachment. It's not an entire like dislocation of the tissue, as it frequently is in Descemet in these complex cases. So I'm comfortable putting a bubble in all of my DMEK patients at the slit lamp. And that means that in these patients, I can do that at the slit lamp and not have to take another trip to the operating room. Then there's the data from Sophie Dang's group that shows that DMEK is non-inferior to Descemet and all the other benefits that we know about DMEK over Descemet in terms of vision, et cetera. Granted that not all of these eyes have, the best of vision potential. But I will say that as eyes have lower vision potential, vision is logarithmic, and having that little extra bit of vision from a DMEK probably makes a big difference to these patients, in my opinion. So this was a study out of Mark Terry's group that showed that Descemet that was performed in eyes with any kind of glaucoma shunt had a higher rate of dislocation due to hypotony, they thought. So 9% versus 2%, 9% in the eyes that had Descemet with hypotony and glaucoma shunts. Compare that to this group out of the UK that showed that the DMEK group that had glaucoma shunts had a 30% rate of detachment compared to 22% in their Descemet group. But notably, all of those detachments were managed at the slit lamp versus those in Descemet were mostly managed in the operating room theater. And this is just to drive home my point that in the big picture, I think that it's probably more efficient, at least in my practice, to do a DMEK and then rebubble at the slit lamp than it is to do a Descemet, do all those other machinations about getting it to stick, and then deal with the rebubble chances where you have to go to the operating room. This is the study by Sophie Dang's group. Basically, it showed that DMEK is at least equivalent to DSEK, if not maybe a little bit better from the perspective of secondary graft failure. And it doesn't really matter if you do DMEK or DSEK. And in my experience, DMEK, DSEK, at the end of the day, as long as the transplant goes in atraumatically, they both will fail in eyes that have glaucomal tubes, period. And so then it's just a question of, all the other factors. We haven't even talked about incision size, where you're putting those things, how many times you can go into an eye with a large incision versus a small incision. I think on balance, DMEK does offer a marginal benefit over DSEK. So let's get into the actual procedure. Case selection and tissue selection. So after your learning curve, and that's, you want to do endo-in DMEK in unicameral eyes, post-vitrectomy, ACIOLs, all those other cases that I brought up earlier. And you would want to do it only when you cannot do endo-out DMEK. And that would be, in my opinion, because generally speaking, endo-out DMEK is going to be a little bit more efficient for you. But during your learning curve, a good place to start will be in eyes where if you can't get the endo-in DMEK to work, you can recover and do an endo-out tap technique. So that would be eyes that are not post-vitrectomy, and I recommend doing that in triple procedures. And that's actually, once I proved to myself that I could do this surgery initially in complex eyes, and that it was beneficial to these patients, and that I really wanted to master it, I shifted away from those complex eyes for a period of time 2 triple procedures to try and really get good with it in easier situations and figure out all the little nuances with where I was going to grab the tissue, et cetera. And then I switch back into the more complex cases. It's true for endo-in DMEK surgery as the same with endo-out tap technique surgery, that older tissue is generally easier to manage. Once you get better at managing the tighter tissue, just like in endo-out DMEK, there's no reason why you can't do 50-something-year-old tissue or even younger once you're good at it. I would say that another major issue with tissue preparation is asking the eye bank to tell you where to grab the tissue. And that's because if you don't grab the tissue at the green circle, as you can see here on the right in cross section, you have a very good chance of pulling the tissue in upside down, because what will happen is everything pivots around your point of grabbing. So I asked the eye bank to put these 2 little dots on the tissue, and I have them grab between those 2 dots when they load it, and then I grab between those 2 dots when I load it, and I do my very best to make sure that I only grab 1 layer of tissue. If you grab 2 layers of tissue, like here, if let's say you got the green and the purple, you're not going to be able to get that thing to fully open. Same thing with the red side. So that's a helpful little tip there. What about recipient preparation? This is all about ergonomics. And so you need to have first a Goldilocks main incision that's watertight, because you need to be able to keep that chamber to allow for that space to open up so that the tissue can open up. And it's also really important that your AC maintainer paracentesis is directly opposite the main incision. And this is when I really try and drive home the point that endo-in DMEK is an ergonomic nightmare. So let me explain to you. So here's a diagram of someone's face, a patient's face, and we're working on the right eye sitting temporal. So what has to happen here, if you're going to sit temporal, and this is still the same if you sit superior, is that this DMEK forceps in pink has to travel over the nasal bridge. And it then has to then grab from the main incision where the endoglide is, and the AC maintainer has to be blowing fluid down the tube of the tissue. So you end up with these 2 incisions that are relatively close to each other. The other point here is that the superior and inferior green paracentesis incisions need to be in a place where you can ergonomically, while you're holding the tissue with the forceps in your non-dominant hand, in this case, which would be my left hand, I need to then be able to take a syringe and pop it into a paracentesis, superior or inferior, depending on what's more advantageous for the tissue, without creating a whole lot of fluid coming out of the eye to make the tissue start flopping around because of the fluid dynamics, and hit the trigger on the syringe, which is a difficult move. So this is the reason why, to me, endo-in DMEK is complicated. And you can imagine if a patient starts moving in this situation and you're locked inside the eye with your hand holding onto the tissue, it's very difficult. None of that is true when you're doing a tap technique. You have free hands, you can do a number of different things. It makes things harder when you're locked into the eye and when you're having to do things with one hand. So what about the left eye? In a left eye, sitting temporal, I got to pull across with my dominant hand, and I have to insert with my non-dominant hand. And that's because if I try and go the other way, I'm going to be pulling over the steepest part of the nose, and there's no way that's going to work. So it's not a coincidence, I don't think, that this is a very popular technique in a part of the world where nasal bridges and brows maybe are not always shaped the same way that they are in parts of Europe and the United States. So ergonomics and paying attention to how your instruments are going to travel over the face is really important. So what if I did a triple, right, in the same left eye? I'm not going to phaco with my non-dominant hand if I can avoid it. And so here I'm going to put the incision just about in the middle, and I will do the phaco. And then what I'll do is that when I'm ready to do the pull through, I have traction sutures that will allow me to give me like 10 or 15 degrees of rotation so that I can now put it in with my left hand, the DMEK, and then reach across my dominant hand and avoid the nasal bridge. And this is another issue that you have to think about, which is that even when you're going over, this part of the brow, like this, or like this, and some people, if they have deep set sockets and a very prominent brow, you're going to have a hard time still accessing the eye and getting across chamber the way you need to. And so the key here is to then tilt the head away from you like this, and then use traction sutures to get the eye to look at the scope again. And if you do LASIK, this is sort of a similar move that you need to do sometimes to avoid the nasal bridge on the gantry, except to induce it here, you have to use, some trickery with sutures to pull the eye into the right angle. So here's a triple just to illustrate the ergonomics of a left eye. And here are some silk traction sutures. And after I finish the cataract surgery, I just put a few degrees of twist without, hurting the optic nerve or anything like that. And that allows me to go easily over the corner of the brow and then pull it across. What about the incision? So as described by Donald Tan, this technique is a scleral incision technique. I prefer to do it clear corneal if I can, to be quite honest. And there are pros and cons to doing one versus the other. If you do a corneal incision, just because of the length of this device, you're going to have a harder time disengaging it from the tissue, as you can see here. Whereas if you do a scleral incision, it's not as far into the anterior chamber. But what you will have a problem with is when you go to try and grab the tissue out of the device, you're going to be like right at the limbus, and it's hard to see the fine detail of this super thin tissue that you're supposed to grab, even with those two dots there. So this becomes difficult as well, although you do have more chamber stability here, and it's usually easier to get the AC to reform in this situation. So here you can see again in picture form that there's relative benefits of putting a scleral incision in versus a corneal incision. Obviously, the corneal incision is going to be easier to close, and this is a 2.6 millimeter incision. So another detail here is that for the recoil forces to be able to work, you have to create enough space for this tissue to flap open. Otherwise, it's going to encounter a frictional force of when it's touching the iris plane. So you need to create that space, which means you need to have a very well-made incision that doesn't leak, that is tight enough to keep the chamber, but loose enough to be able to exit the chamber. And I'll show you what I mean by that. So here's an example of the wonders of having a trainee with you, because my incision is leaky. I mean, it was really easy for me to come out of the eye, but it's leaking like crazy. And so you can see nothing is going on. It doesn't help that the AC maintainer isn't exactly blowing at the tissue, but nothing's going on. It's stuck against the iris. And so what ends up happening here, even as I try and hold that incision shut, is I have my assistant, who I believe at this point was Andy Blitzer, who's now at NYU, close the incision. And this entire time, mind you, I haven't been able to exit the eye because I'm holding onto it with forceps. So again, a difficulty of endo and DMEK is that you're kind of locked in until you can let go of that tissue. And so now with the chamber, forming again, there's more space and the tissue ends up opening itself, and then I can eventually get a bubble in there. So again, very important to be able to keep that chamber, and that's all about the incisions. And that was a difficult placement of that bubble, also with one hand, while the other hand is holding the tissue. So to drive home the point, you need a chamber to make the tissue recoil. What about infusion control? So endo and DMEK, in my opinion, lives and dies by the infusion, and it's different, I think, if you use a Descemet. You do need an assistant to be able to operate that. And in my hands, I'm fine with using an AC maintainer, but I have to work the pedal a lot to turn it on and off as needed. So when you insert the tissue, you have to have the infusion off. I've made this mistake. If you try and open up the incision with a bunch of fluid coming out, it can go right into the endoglide and then shoot the tissue back out. And that is not a good day. Once you get into the chamber, and you have to be relatively brisk with that, otherwise the chamber will collapse all over the inserter. But as soon as I have a reasonable seal, I turn the infusion back on, and then I get fully into the eye. And then when I have the tissue across the chamber, I then shut the infusion off and exit with the infusion off. It's written about in the original papers that if you don't do this, there's a good chance that with the flow of the tissue of the fluid coming out the main incision, that you could lose the tissue off the forceps. I've never seen it, but it's not something that you'd want to have. So infusion off when you come out. And then at this point, you're turning the infusion back on. hopefully to blow the tissue open. You're moving the forceps to be right in front of the infusion. And then you're turning it on and off and on and off until you get it to open the tissue the way that you want to. And then whether or not you have it on or off, you keep it with the way that it is, with the tissue being the most stable to be able to get a bubble underneath it. So if I have the tissue sitting pretty and the infusion's on, I'll go right in underneath it and put the bubble in. If I have this tissue sitting pretty and the infusion's off, and every time I turn it back on, it makes the tissue flop around, I'll shut it off and I'll go in and put a bubble underneath it. The infusion is an important part of the surgery. And you have to set the IOP to not that high. 20 to 25 millimeters mercury is what I use. 50 is too fast. What about pulling through? So when you pull through, the tendency is to want to pull it right towards the paracentesis, but you want to pull it actually pivoting a little bit. So you're introducing or presenting it to the flow from the AC maintainer, which then helps the tissue open up. That's that flow force that we talked about earlier. Here's a good example of what that looks like. And you can see it's not exactly in line with the para. It's pulling it with a pivot towards the AC maintainer. This is a Yamane combined with a DMEK pull through. And one thing I want to point out to you is that the AC maintainer is across chamber from the main incision, but it's not pointing at it. And it's now introducing a vector force of flow that has just taken that tissue and flipped it upside down. And so then I have to go in now with one hand while I'm still holding the tissue to flip the tissue back around the pivot point of the forceps. And this is not easy. And then I'm just working the forceps to be up against the cornea with the AC maintainer blowing a fluid current that's helping to open it. And now it's opening all the way. And now I have to get in the eye one-handed to place the bubble. Not easy. And the point here that I'm trying to make is not only do you have to have the right vector of fluid current, but you really need the tissue to be up high against the cornea. If you don't pull the tissue up high against the cornea, what will happen is it will just recoil. And so your ideal case is like the lab on the right, where you pull up high, and when you pull up high and the chamber's deep, it just pops right open and then job done. And that's this case, as you can see here on the left. If you pull down low, it will just recoil. And I definitely had a case like this early on. And it's not intuitive to have to sort of drop your wrist really hard to pull this up high towards the cornea, particularly when you think about the ergonomics, you're really up hard against someone's nasal brow here. What about exiting? So let's say you have the tissue open, you're ready, or not open, you have the tissue fully inserted, you're getting ready to open it, but you have to first get the inserter out. So on the left, you'll notice that I'm wiggling the heck out of this thing. And I do have an assistant with me, but I wave them off and I say, no, I think I got it. And this is all to have a watertight chamber, okay? And that is a really difficult exit, but then I have a chamber that's holding and I'm happy. On the right here, it was so tight that I had to have my assistant hold the incision for me to be able to exit. And one needs to really pay attention when you do this, because one problem you can have when you pull that inserter out is you can pull the eye with it. And then if you're locking in your 27 gauge DMEK forceps without really paying attention to where everything else is going, you could end up pulling the eye off the tissue so that the tissue pulls right through the paracentesis. Seen it happen. It's not a good day. It requires a lot of awareness when you're exiting the eye. You have to be paying attention to the chamber, your forceps position, the tissue position, the AC maintainer position, as well as lastly, the inserter position and how it's doing in the main incision. I'll say that bubbling one-handed is very difficult, particularly if the AC maintainer is not on. And in this case, I kept it off because every time I turned it on, it was fluttering in a funny way that I couldn't seem to control. And so I just got underneath it with a bubble with one hand and placed the bubble. And you can see I'm like underneath it forever before I finally place it. And that's because I couldn't, with one hand, get the plunger to move sufficiently. And I'd love to tell you this never happens, but it happens. And it's one of the things that makes the surgery very difficult to do. I have tried to solve this with something called this syringe adapter basically goes on a 1 cc syringe, and it allows you to just push it with your finger, and so you don't have to reach around and figure out some way to grab this and then grab it and hit the top. This just puts it all at your fingertips. I do have a conflict of interest with this, and it's sold on Iowa Made. Pivot to release coaxial forceps. This is the very end of the case. So the way that these forceps work is if you pull them straight out the incision, it's going to keep them clamped down really tight. So you actually have to push in towards the tissue, pivot away, and then come out. Otherwise, you will pull the tissue with you outside the AC maintainer, because every time when you think that you let go of it, actually you're holding onto it really tight, because it's the teeth of the jaws of the forceps are being held shut by the paracentesis. So you got to push in, pivot away, and then get out. And let me show you that video, what that looks like again, one more time for you to see. So here's the bubble, and then I pivot away and then get out. Okay, centering the tissue. So, and we're nearing the end here. Endo-in DMEK to me is all about winning ugly. So maybe for me, when I was starting to do endo out tap technique DMEK, I was thinking a lot about like just getting it perfectly in the rhexis, then putting the bubble in it and putting a perfect bubble underneath it and not wanting to move it. These days, I'm much more interested in getting the thing off the iris plane as quickly as possible, getting it mostly open as quickly as possible, getting control as quickly as possible, and then using this technique I'm going to show you to scoot the tissue in a very accurate way in different directions with a small little bubble underneath it. So to do this and to be a closer, to win the case, you want to put only a small bubble in the first time. If you put in a big bubble and then shrink it, you will have pushed all the interface fluid out of the interface, which is fine, but then you have to reintroduce that fluid to get the tissue to move again, because what we're after is an eye that is held, a cornea that, a corneal DMEK graft that is held only in place up against the cornea above it by a small little point of contact, and everywhere else to be filled with fluid. So that when we hit the cornea, the bubble drops and the tissue scoots, because it's floating, if you will, in a negative sort of way, in an opposite way, on a fluid bed between it and the overlying cornea. So let me show you what that looks like, and we'll move on from there. So to me, it's all about taking these golf swing divots. I'm a horrible golfer, but and I take really big divots sometimes. But what we're after here, okay, is I'm moving the head so that this is now all facing downhill, and I am using that tiny bubble to allow me to scoot the tissue downwards. Let me show you that because it's sort of fast. But there's a small bubble there, and then you'll see that just from doing that, the tissue scoots towards that temporal dot. So here's that space, and then at the end, it's on the dot. And that is from having a small bubble and having interface fluid. So here are the high points. Think about ergonomics when you do endo-in DMEK. Think about the infusion. And make sure that you have it on and off at the critical points of the procedure. Really think hard about your pull-through trajectory and pull towards the AC maintainer, and win ugly. Get a small bubble underneath there, keep the interface fluid there. If you have to, shrink the bubble, reintroduce some interface fluid by just like leaning on the cornea and making parts of it sort of bend in certain ways to let fluid in there, and then just scoot it along by grazing the cornea like you're taking a divot out of grass. That's all I've got, except for this last piece, which is how I bubble my transplants at the slit lamp. I came up with this, gosh, it's like 11 years ago now, when I was a fellow with Mark Terry. And basically, you just stick a cannula on extension tubing, and then hook that up to something bigger, like a 5 or 10 cc syringe. Open up the paracentesis, and then purposely drain fluid out with that forcep, or you can do it with the cannula itself, and then cannulate the paracentesis. Now that the AC has been dumped of some fluid, it has some space for a bubble, and then just make sure that you're on the iris plane, just about posterior to the DMEK graft, and then you drop the bubble, and Make sure you inject relatively briskly so you don't have cavitation, and then you get out and check it for leakage. Thank you so much for your attention, and I'm happy to answer any questions. I'm going to stop the share. My kids are older than this now, but it's still a funny slide.
Thank you
Mike?
so much, Dr. Salas. I have a quick question to get
Sure.
started. For forceps, what do you use?
Mhm.
Do you think like a lot of the available bent grasping forceps on the market are 23 gauge? What do you use, and do you think a 23 gauge forcep is appropriate for endo and DMEK?
I have not used a 23 gauge, but I imagine that it would work just fine. I've used a 27 for the longest time. I've used Coronet has one available that's a bent 27 gauge. Before I used that, I would bend my own 27 or 25 gauge retina forceps. If you do that, don't just take it and bend it. It won't slide anymore. You have to slowly bend a nice little arc in there. You can get like a nice arc and do that with your favorite pair of retina forceps. They both work. MST forceps are not usually quite long enough. They may get a little bit more difficult from an ergonomic perspective. With the 27s, you have to just pay a lot of attention to what's going on because they bend like they're super flimsy, and you got to really pay attention to what's going on. Whereas the 25 and 23s are, a little bit easier to work with, but I think it's dealer's choice.
One of the most common questions I get is about forceps. We have several questions.
Mhm.
So the first one is, do you ever do this endo in technique without infusion?
Yeah, it wouldn't work unless you have to have some source of AC maintenance because and so that can come from an AC maintainer. It can come from like a Descepro. Right? And the Descepro is just for those who are not familiar with it. Basically, it's a sleeve, excuse me. It's a sleeve that goes over the forcep and has enough fluid pass by so that when it's hooked up to a large syringe, your assistant can reinfuse the AC and it can also appropriately blow some fluid coaxial with the forcep. So what the AC maintainer is essentially doing is all of that. But number one, if you go cross chamber with a pair of forceps in an eye that doesn't have viscoelastic, it will collapse. And you're going to have a hard time seeing anything and getting cross chamber, etc. I suppose it's possible that you could have an assistant just sit there and infuse with like, a syringe. It would be messy. And so you do need some way to do AC maintenance. And those are two ways to do it. And neither of them is perfect. Neither of them is perfect.
Thank you. We have four more questions. So the next question is, do you consider DMEK in patients with glaucoma tubes or traumatic / post-surgical pupils?
Yes, the answer is yes. I consider DMEK in all patients. I try to at least. So at least half my cases are patients with glaucoma tubes, at least. And that's because we're at the University of Iowa and we've got a very mature, well-established, like decades old glaucoma practice that has like a bottomless pit of like destroyed corneas from glaucoma. I hope that there's no glaucoma surgeons on, but like glaucoma surgery like ruins a lot of corneas, but like not necessarily so, right? Otherwise they'd have no nerve. So a lot of those patients, traumatic iris problems, yeah, absolutely. See it all the time. Um, I probably at this point in those cases, because I know a lot of them will have photophobia. If they have photophobia, I move them towards like a vitrectomy with one of my colleagues, and I put in an iris prosthesis if I need to suture it in, etc. Or I put one in passively in the sulcus, and then I'll do a DMEK pull through on top of that.
I guess a logical follow-up question to that is, what for you, since you've sort of mastered this endo in technique, what for you would make you choose to do a Descemet in a patient?
I've done that. I can count. So I've been here for 5 years, and and before that, I was at Cornell for 5 years. I can count on both hands how many DeSakes I've done, and I've done a lot of transplants here. I don't think I have a scientific answer for that. My answer to you is more that when I've had repeated DMEK failures, like in eyes, and I'm talking where the transplant is smooth, there's no reason to think that there was anything about the surgery that destroyed the transplant. And yeah, I think you have to be honest with yourself if that's the case. Um, After the second DMEK in these patients, I can't look at them in the eye and be like, I've tried everything, because I haven't yet. I haven't tried like a Descemet. I haven't tried a PK, right? And so then I'll offer them. I'm like, there's no data to support this being better than a DMEK, but at least it's different. And sometimes eyes don't read the textbook. Maybe this will work better in you. And then I'll put a Descemet in them, and then that fails, and then we do PK, and then like that fails. So it's in these very difficult eyes. I think and I think the data supports this. It doesn't much matter what kind of transplant you put in them. When they failed more than one transplant, they're going to keep on failing. And in those cases, I then start to wonder whether or not it makes a difference doing one or the other. And I'll tell you, every time I do a Descemet in those eyes, and I'm like, this isn't easier than the DMEK. Like, I don't know what everyone's talking about. Like, this is a very difficult eye, and this is difficult. The only thing that would be potentially easier than this is doing a PK. And at certain point, I start to think about that as well, or like K pros and what have you.
Multiple failures. That's interesting. The next question up is, well, we have a comment, which is, thank you, nice lecture. And then from the same participant, the question is, what is the infusion pressure that you use?
Yeah, 25 to 30 is about what I use. And I found that faster than that can like create like a little too much turbulence. The key for all of the infusion though is that you have good incisions and that they don't leak. Because even at a low infusion, particularly if you run with an Alcon system because of the active fluidics, it will infuse fast. It will keep on infusing faster to try and hit that IOP. So if you've got a leaky main incision and a bunch of fluids flowing through there, it doesn't matter whether you're at 25 or 50, it's still going to be cranking tons of fluid through there. And it's going to be making this tissue like go all over the place. So you have to have really good incisions, and you have to not be like burping the heck out of the paracentesis incision that you're putting the DMEK forceps through. Otherwise, that creates a flow force as well. And all of this stuff just requires a lot of sensitivity and finesse around how you get in and out of the eye.
Our next question comes from Japan. When I add air post-op, I always do it in the OR. Air injection on slit lamp, does that cause endophthalmitis or graft dislocation?
Yeah, it's a good question. I've never had a case of endophthalmitis, knock on wood, from injecting at the slit lamp. I don't think it is any more invasive than a vitreoretinal injection. All the appropriate precautions with iodine before and after, etc. But I haven't, and then make sure it's not leaking, I think is the main thing also at the end of it. Like Sidel it, make sure it's not leaking and everything's fine. I think it's fine. Dislocations. I think you can have a dislocation at the slit lamp in the same way you can have a dislocation in the operating room theater if you put the bubble in the interface. So as long as you're behind that tissue, there's no way that you can have a dislocation. And as long as the tissue is partially attached, typically superiorly, because then the bubble goes up there and then it expands downwards and it holds everything in place. In the operating room theater, it's the same idea. You're just putting it right up against the apex and then it expands outwards. So I don't think that either way is a problem, but not everyone's comfortable with doing it at the slit lamp. I just find it to be, it's just the way that I've always done it. I've done it that way for like 10 plus years. And, if you want to play averages, it's probably like a 20%, for being honest about it with all of these complex cases or more rebubble rate. So do the math on that for probably something like 1,000 cases. And so like, that's how many I've done at the slit lamp. And none of them have had endophthalmitis. And I haven't dislocated one actually ever. So, but I haven't rebubbled ones where it's like a sitting as a scroll. Okay. So like the
Yeah.
two that come to memory where like the tissue is sitting as a scroll in the AC, like you can't rebubble that. Like that's gotta go, that's operating room.
Is your threshold for rebubbling like a third detachment or less?
That has also have been a shifting, that's shifted for me over the past 10 years also, I'd say. In the beginning, that's what was published like early on, right? In the Mellis papers, et cetera. Because rebubbling is not a big deal to me, I listen to my patient, and if they're like fed up with their blurry vision, I'll be like, you want to give me another 24 hours on your back at week 2, and then we'll have it hooked up, pop the bubble in. And that could be for, less than 30%. And it's a lot more to do with rapidity of the vision recovery for the patient. In complex cases, like we're talking about here, to me, the bubble is all about making sure it doesn't fall off. So if they have a tube, or they have, let's just call it like my practice, like they got 2 tubes and a trab, okay, and like they don't hold on to anything, I am seeing them not at 1 week only. I'm seeing them like at 3 days, because I'm pretty sure that bubble is going to be gone. And I don't want to miss the boat if the tissue hasn't really started to hook up yet. Because some of those cases when there's no bubble, you've all seen this. You've seen a patient who has like almost no bubble after like, a week. And who cares? The tissue's great. It's compacting. It's fantastic. No one has any complaints. But you've also seen patients who have, um, you know, no bubble at 2 weeks, and the tissue looks like miserable, right? And you're like, I'm so glad that I got this bubble in there wherever you did it, so that the tissue has had a chance to reattach. So I never want to be in a situation at like day 3, for example, with a tissue that's not going to be reattaching, and no one has a crystal ball as to which ones are going to attach quickly and which ones are not. And so I want to make sure that that tissue has tamponade underneath it if it shows any signs that it may be the one that wants to fall off. So I see them more frequently when I think I'm going to lose tamponade. And this is whether they're endo in or endo out. This has to do with bubble retention, which is a separate, completely separate conversation. And it has nothing to do with the method of insertion. It has to do with whether or not they hold on to that bubble. So does that help answer that question?
I think so. We'll see if we hear anything else in the chat from that person. The next question up is for those like you who are asking for the tissue with 2 dots that show you where to grab. Who determines the distance between the dots, the surgeon or the eye bank processing technician?
I think that's a team effort. And so I asked them for dots. They made the dots. In the beginning, the dots were like way too big. And then they became right. And I was like, that's good. That's the one I want. And the thing is that they have feedback, right? Because their feedback is they have to first pull it through to load it. If you're doing like preloaded endo in, and I do preloaded endo in. Whether or not I would do endo in without preloaded is another question. I probably wouldn't. They have to pull it through by those dots. So if they have a hard time pulling it through, you're going to have a hard time pulling it through. So they're going to probably get it right on their own without having to tell you.
Yeah. And from the same person, can you elaborate on why glaucoma surgery ruins the cornea?
I don't know why. I have an epidemiology background. I don't have a science background. I can just tell you epidemiologically, it's true, right? That the main predictor for life of the transplant and for failure of the transplant is the diagnosis at transplant. So Fuchs dystrophy patients do better than pseudophakic bullous keratopathy, who do better than glaucoma patients with a tube, who do worse than glaucoma patients with a drop, who do worse than patients who don't have glaucoma at all. And so the underlying diagnoses are the driving factors for how well these transplants do, holding all other things constant. And it doesn't help that these complex eyes are harder to do transplants in, right? So they're going to be more likely to have other traumas, but even holding those constant, they don't do as well.
The last question we have for now is to use AIR or SF6 at the end.
At the time of surgery, I'll use SF6. I do 16%. Why do I do 16%? Because it's less than 20, and I don't want to be bumping up against that. And in the clinic, I'll use air to rebubble, with rare exceptions in patients who maybe they can't position as well. I might use something else. So hopefully that answers that question.
Yeah. And I think that's all We have for questions in the chat. There were quite a few, so thank you for taking the time to go through and answer them thoroughly. And thank you for the talk. It's greatly appreciated. This is a very in-depth talk on endo pull-through DMEK, which is quite a hot topic right now. It's not very popular in the US at the moment, but I think it is gaining a lot of traction. Thank you to all the participants for logging on tonight and engaging with us. Please remember to complete the brief survey that's going to populate as soon as we end the webinar. Do you have any final thoughts or words, Dr. Salas?
No, thank you so much for your time. I know this is late on the East Coast, and I thank you very much. Thank you again, Eversight, and thank you for organizing everything. Thank you.
Thank you. Good night, everyone.
Good night.